How you doing?
Fine, thank you.
Yeah, thanks for your help the other day. That was a good conference with yeah, that was really good.
Yeah, I know.
And I didn't know I was going to do it until like an hour before.
Oh, yeah.
Yeah,
Doctor, yeah, told me that.
yeah, so we had to prepare fast.
Yeah,
But it went well, and I
but
think he liked
yeah,
it.
it's
He liked it. He's going to do
yeah,
more. He's going to do more.
yeah. He liked it very much,
Yeah.
and it went smoothly.
Well, he travels all around the world.
Yeah,
Yeah, yeah, we'll be able to follow him. Well,
yeah,
because as he said, he goes to Nicaragua, Mexico. He goes everywhere, Europe.
yeah. It's a nice
So
thing, actually.
yeah, so he was a good guy to meet, very good guy to meet,
Yeah,
and we hope to continue to do that in the Arabic world. So
yeah. I hope so. I hope so, and we will. I think we will.
yeah, we will. We're ready. We're getting a little better with production, with
Yeah,
editing. Like we took out the bad parts. Remember the other day he had a hard time getting the screen share. We cut that out.
yeah. Oh, I saw that. Yes.
Yeah, yeah. So it makes it better for their resume because I think they'll begin collecting a resume of the speeches that they give
Yeah.
in
Yes.
conferences. It's a shame. They go to conferences, they spend the time, but no one ever sees it.
Yeah. Yeah. Actually, just the audience saw it.
Yeah,
Yes.
just the audience. And some of them are very good talks. So it's good to have them. Anyways, I'll let you do your work.
Yeah. Okay.
Okay.
I'll text you before we start, like
Okay.
usual.
Okay. Greetings, Galaxy A20. And Musindo, hello. Can you unmute yourself and introduce yourself? Musindo and hello. Hi, Musindo. Okay, Galaxy A20. Hello, Galaxy. Okay, come in. Ground control, the Major Tom. Good. Hi, Dr. Sabea. Hello, Dr. Sabea. I guess you can't hear.
Assalamu alaikum, Masal Khair. Good evening. My name is Ibrahim Sweih. I'm a neurosurgeon, and we are transmitting live from the Farah Medical Campus here in Amman, Jordan. The backdrop is this view of the baptism site over the River Jordan, which is the only site of official baptism. We in Jordan believe in the tolerance of the others, and if you are a Muslim, you would believe in God and His prophets. We believe in the Bible, we believe in the Torah, and we believe in the messengers. Tonight we'll present this unusual lesion of the skull. This is just one cut of the patient's skull X-ray and MRI, CT and MRI. I want you to keep this view in your mind as we go through what this could be. So we're talking about Calvarial lesions. We have something called normal variant. Arachnoid granulation, parietal foramina, venous lakes. These are normal variants, but people may judge as lesions. Arachnoid granulation, look at this. You may call this a lesion, while it is just normal arachnoid granulation. You and I have these two parietal foramina for two parietal emissary veins. Sometimes the parietal foramina are very large, and you would suspect a lesion, like this case. Easily you may suspect a lesion, while this is the normal parietal foramina, but enlarged. Also, venous lakes within the skull. Skull is full of diploic channels, and unsuspected person would diagnose this as a lesion. Other calvarial lesions are the congenital ones. Other anomalies or lesions like hydrocephalus, encephalocele, dermoid, epithermoid, and fibrous dysplasia. This is the hydrocephalus, and you can see the so-called silver beetle appearance. But as I say, I always say that the shunt is the disease of the underdeveloped world. It is a disease in Jordan, it is a disease in the Arab world, disease in Asia, where people are just interested in putting shunts like this. So you see this very often, so many shunts and revisions of shunts for no good reason. Encephalocele, dermoid. Again, if you have kept the image that I showed you at the very beginning, you may say that this is very similar to it. So is this lesion a dermoid cyst? Epidermoid, like this. This is one of my cases. Epidermoid inside the skull. Another epidermoids that looks very much like our case. Fibrous dysplasia. Fibrous dysplasia, they go into the vault and they also go into the skull base. Again, if you look here, you suspect there is other tumors. One case of mine is this boy with this fibrous dysplasia. He lives in Jordan, but he's from a Filipino mother. Fibrous dysplasia. Trauma as acquired, because what we do is to think of the lesions as congenital or acquired. And if you start with the acquired, you start with the trauma, cephal hematoma, leptomeningeal cyst, burr holes, cranectomy, aneurysmal bone cysts. So this is a case of trauma where there is bone defect, say after elevation of a depressed fracture. Suberosteal cephal hematoma, you see this in kids where there is blood underneath the periosteum. So it is suberosteal cephal hematoma and it can calcify. You also suspect it as a tumor, for example. Look at this cephal hematoma and how it looks on surgery. Leptomeningeal cyst, which is called disappearing skull fracture. You have skull fracture which gets enlarged gradually and causes this defect. Burr holes, they will leave a defect. Aneurysmal bone cyst, like this. Again, if you have kept the image that I showed you before, this could be it. This could be an aneurysmal bone cyst. And I put it with the trauma because the accepted theory of aneurysmal bone cyst is trauma. Aneurysmal bone cysts. Very much like our case. Paper from India about this. And look at this bone cyst within the frontal bone. Also, we are still in the acquired stage, trauma acquired, hematological diseases, chronic anemia, so-called hair on ends, زي اللي شعر راسه موقف من الخوف. This is the skull because of the anemia, hair on end. Or you may get mass within the skull and then the brain in leukemias. Still in the acquired, idiopathic disorders, Langerhans histiocytosis and Paget's disease. Histiocytosis, bone defects, usually in children, but it can affect anybody. This is the advanced stage of the histiocytosis called Hand-Schiller-Christian disease, after the three people who found this. It's a systemic disease, and usually it's a killer. Paget's disease, after Sir Paget from England, with this bone changes. Calvarial lesions acquired. infection. Osteomyelitis of the skull. We only think of osteomyelitis in the tibia. It can happen in the skull due to minor trauma. Look at this. Bone lesion due to osteomyelitis. Osteomyelitis, look at this boy with this pus coming out due to osteomyelitis after minor trauma. This paper from Turkey. We keep forgetting about TB. We always forget about TB and lymphomas. Look at this. The incidence of TB of the skull is on the rise of the skull in developing countries with a worldwide resurgence of TB in the world due to migration to developed countries. So people from underdeveloped countries, they migrate to developed countries and they take their TB with them, TB in the lungs, TB in the bones, and TB in the skull. Paper from Malaysia, 2014, look at this. And this was without pulmonary TB, just isolated TB of the skull, without a primary source.
How it comes?
It's usually there's a blood-borne disease, it passes the lung and goes to the tuberculosis of the skull mimicking a bony tumor. Look at this. From India, of course, TB. But remember, tuberculosis is still endemic in our part of the world. Bone defect, mass. Echinococcus granulosus, hydatid disease of the orbit. They love to go into the vertebrae, they love to go into skull bones, and here it is in the orbit. Syphilitic, tertiary syphilis. Although people say that syphilis has ended in the world, I disagree. In the Calvarial lesions, the acquired, we think of vascular lesions, AVM, like this. Cercoid aneurysm, like this, eating the bone. If you happen to think that this is sebaceous cyst and open it in the clinic, patient will die. Tumors, benign tumors, hemangioma, the whole list. Hemangioma. It is one of the commonest skull lesions. Look at this, very much like our case. In fact, it's almost identical. Hemangioma. Hemangioma. Primary hemangioma on the frontal bone. Look how it looks when you open on it. Osteoma. The ENT see this osteoma in the frontal sinus and smooth sinus and so on. You will see it in the skull like this, skull lesion. Osteoid osteoma, which is a special type of osteoma. Osteoblastoma, benign tumor. Osteoblastoma in the parietal bone from South Korea. Histologically verified. Again, people have stopped to think of pathology. You only think of one or two pathologies in your career, and this is the disaster about the thing. Osteoblastoma frontal bone. Again, if you remember the image of I put it at the beginning, this is very much like our case. Could this our case be a hemangioma? Another osteoblastoma, 2017. Very much like our case. Osteoblastoma of the occipital bone, temporal bone from USA. Brown tumor or osteoclastoma. Giant cell tumor of the sphenoid bone. And we have the category of intraosseous meningiomas, like this. Meningioma just inside the bone. I did not put any orbitomeningeal meningiomas because they are a special entity. But look at this. This is a tumor inside the bone. People call it hyperostosis. Wrong. This terminology has been dropped 30 years ago. Still, the mediocre people are still using it. Interosseous meningioma. This was a patient from Kurdistan, which I did recently. He immigrated to Australia. Look at this, again, very much like our case. Again, this was a case of mine, a lady from Egypt. Similar to the meningioma is hemangiopericytoma. And this very odd thing, the interosseous schwannoma within the bone. There have been very few scattered reports about it. Interosseous schwannoma, imagine. LYMPHOMA, this has been published, and this is the publication. Still in the acquired, we have the malignant. The malignant could be a primary, could be secondary. Primary tumors and secondary tumors. Primary tumors, plasmacytoma, the single tumor or multiple myelomas. This is multiple myeloma, multiple myeloma, multiple. This is single, single, single. Look at this. Multiple myeloma. Osteosarcoma of the bone. Chondrosarcoma. Angiosarcoma. Rhabdomyosarcoma. Rhabdomyosarcoma of the skull. Who would think about it? Lymphoma. And this is serious. Bone involvement is common in many types of lymphomas. Skull lymphoma is a very rare presentation. Look at this. Lymphoma in the skull. Paper, lymphoma from Brazil, 2010, involving the bone, the soft tissue, and intracranially. This has been histologically verified. It is not a mental exercise. These are pathologies that you, and I hope you, would think about it in the future in your practice. Lymphoma. Ewing sarcoma. Ewing sarcoma of the skull bone, imagine. Meningiosarcoma. This is one case of mine, which I did some time ago. Chondrosarcoma. Metastasis. People say, well, if it is large, it is not metastasis. They can be very large. They can be single metastasis. So this is a huge metastasis. It could be from anywhere, lung and breast and everywhere. Colon, look at this, huge metastasis. Very much like our case. Metastasis. So after all this run of what is the differential diagnosis, again, we have to come back to realities. The commonest lesions are these large ones: osteomas, meningioma, fibrous dysplasia, epidermoid cyst, eosinophilic granuloma, and the rest are this small chunk. But you have to think about them. Please, yes?
So, a long time ago, when medical schools were medical schools, junior medical students were required to know every single layer from the scalp until you get to the brain, and the constituents of every layer and the cells of every tissue. And the reason for that is that when you know this, you would explain why we have been discussing this extensive differential diagnosis over the last 10 minutes. So every single cell in every single tissue, in every single layer, can give rise to a malignancy, not to mention the systemic disorders, infections, etc. Now, from an oncological perspective, first thing, you really need to know that this is not infection, and you don't want to miss TB and assume that this is cancerous. But this extensive differential diagnosis and this reflection of true cases of each one of them, this is why that really used to happen. But these cases, these cases are true cases. I'm going just to fixate upon the malignant part, emphasizing the important, emphasizing the importance of TB to be ruled out. But mets can present in this fashion. Breast cancer can metastasize in this pattern. Thyroid can metastasize in this pattern, including these big masses. Lung can metastasize in this pattern, including these big masses. Now, sarcomas, because of the soft tissue in the area, would be on the differential, and there's a very big difference. Are you dealing with Ewing sarcoma, where the mainstay of treatment is going to be multi-agent chemotherapy for numerous cycles, then surgery, radiotherapy, and then more chemotherapy, and the treatment would be something for a year. Lymphoma keeps hammered in every meeting of ours. One, because despite the rare site of lymphoma being a primary a malignancy in this site, skull-based, when you see enough lymphomas and enough skull-based tumors, you're going to see them. And these patients will not need a surgery. They need a biopsy, they need a diagnosis, and they may be cured with chemotherapy alone or radiotherapy alone, depending upon which one of the 100 or so types of lymphoma are presenting in this. Most lymphomas that present in this pattern will be diffuse large B-cell lymphoma that would be cured with chemotherapy alone, plus minus radiotherapy consolidation at the end. There's a very big difference between dealing with angiosarcoma and other Ewing sarcomas. Angiosarcomas are horrible in this site, and you really want to know that they don't harbor Kaposi sarcomas as well. Chondrosarcomas don't really respond much neither to chemotherapy nor to radiotherapy, and the mainstay would be surgery. Now, the difference between plasmacytoma and multiple myeloma is plasmacytoma is a single lesion in one side of the body, where multiple myeloma is part of a systemic disease where numerous parts of the bone are involved, as well as the bone marrow. And plasmacytoma alone, when you have ruled out multiple myeloma from the body, this patient would have been cured with radiotherapy alone. Once we have known the diagnosis, they would not need surgery. Radiotherapy alone, if it is plasmacytoma, not multiple myeloma, would have cured these patients. And probably plasmacytoma is a more common tumor than lymphomas in this part of it. Now, we keep hammering these points every week. These patients, a lot of them, plasmacytomas, lymphomas, would have been spared surgery had you known the correct diagnosis, and they would have been cured with chemotherapy, radiotherapy, or both. A lot of the sarcoma scenarios would have needed multi-agent chemotherapy, surgery, and plus minus radiotherapy, depending upon which type of sarcoma you're dealing with. And please don't forget that TB is still rampant in our world, and more people die of it than I care to mention. Is Dr. Muntasir in the audience? No. Okay. Thank you.
I hope the message is being taken loud and clear. You have to stop thinking about one or two pathologies, and you have to think in a grand fashion if you want to succeed in your life and save patients' lives. So back to our case. The unusual skull lesion. This is a 27-year-old Iraqi girl. And recently I've been very skeptical about patients coming from Iraq because of the many weapons of mass destruction that were used against that country. This unfortunate girl had 1-year history of mild headaches. And again, headache in the Arab world, in the underdeveloped countries, is thought of very lightly. وجع راس زي اللي بيجي لكل الناس باخد لها حبتين بنادول وبروح هذا مش شيء. This was the complaint of this lady, mild headache, which increased in severity. So she went here and there, and a very intelligent ENT surgeon said, oh, you have nasal septal deviation. This is the cause of the headache. Is it? When Mahmoud? Is it? It's not. But here in Jordan, ENT people diagnose that the cause of headache is nasal septal deviation or a small thickening of the mucosa, and they do surgery for people. People have lost their noses and tonsils. And so on.
There is one limited time where the sphere of the septum can affect the lateral wall and make nasal neuralgia, which is due to this. This is very, very rare. And you can tell that if you give him decongestant and disappear.
That's not the case. Okay. So after septoplasty, she did not improve. Her headaches actually progressed, which is expected, and increased in severity. She went for a neurologist. Oh, this is migraine. This is the easy and simple diagnosis, migraine. Analgesia and others, no improvement. Vital signs were normal. Neurological examination was normal. Cranial nerve cerebellar signs negative. Lumbargasm negative. Sphincters normal. This is the girl, 27, beautiful girl. Eye movements are okay. No facial weakness. Ophthalmology showed nothing by examination. No weakness in her upper or lower limbs. Normal neurological examination. Her chest X-ray and ECG were normal. CBC bleeding profile normal. Kidney functions, electrolytes normal. Liver functions normal. And these are her images again. Look at this. CT scan, bone window, still bone window. And think of what of the other lesions that we saw could be the cause of this. Do we have radiologist, Doctor?
So this is typical
Hemangioma, right?
because it's diagnosed radicularly. It's not a basket.
Yes, that was my diagnosis.
Yeah.
That this is a hemangioma. Anybody else? Any radiologist or anybody? Neurosurgeons, residents, anybody? Any comment? Ahmed, what do you think? Hello? What do you think of this? Come on. Hemangioma, hemangioperocytoma. Dr. Mohammed Khatib, what do you think?
Yes, the same, sir.
Same. Anybody else? Huh? Metastasis. Okay. Look at this. This is the MRI. Look at this. Coronal and sagittal. So we agreed on surgery and we wrote this consent form. As I always say that you have to have a very special consent form for each patient. There's nothing called general consent form. I hope you realize this before it's too late. You have to write a consent which is tailored for that particular case. And in this case, I was traveling outside Jordan, so I told the patient that I am traveling because she has to know that I'm leaving and somebody else is going to look after her. Should surgery? Okay, so we have opened the flap and we came to the bone. We are removing here the periosteum, the periosteal elevator. But look at here, the outer cortex is gone. This bone here is all destroyed by this lesion. So this is just the periosteum with the cortical layer of the bone being removed. Bone is very soft, as you can see, extremely soft. We do burr holes so that we will go around it in the lesion, because we don't know how deep it is and what is, if it is really invading the dura or not. So we would do burr holes around it and go around it. And here you can see they are separating whatever left of bone from the dura. Again, the use of a drill is a must for any neurosurgeon. It is not a luxury. It is in the domain of any average neurosurgeon. As I said, if you want to learn drilling, learn it from the ENT people. They are the best drillers in the world. So this is the dura, where the tumor is attached. We have gone around the edge of the tumor. Again, here there is no biopsy, and let's stop here. We have to do radical thing. This patient has a chance, and this chance is now.
Doesn't look vascular.
Not much, no. And this is done under the microscope. No neurosurgical procedure should be done with the naked eye. Neurosurgery is microscopic surgery, even on the skull, Here I'm opening the dura because I don't know what's the histology. If this is malignant and it is attached to the dura, some cells will be embedded in the dura. So better to open the dura and remove it completely and send it for histology.
ما هي المادة التي تعرضون فيها
Two types, either we take from the patient himself, ناخذ fasciolata from the thigh or temporalis fascia, or we use a cadaveric fascia, ready fascia, and we suture it like this. I use this also to cover over the defect, and I use the mesh to cover the bony defect. Remember, this is a girl, she's 27-year-old, and we need to serve her well. Okay. Histology. Dr. Sam.
As you could see, this is neurofibroma. This is not hemangioma. You could see, it was not really vascular, and there was bony pieces and soft tissue in this component. I will talk about the immune also as I go. This is really typical of the neurofibroma. I will show you. See, it's myxoid. If you remember the gross that Dr. Prime showed you, it was soft myxoid, and there's a lot of collagen. This is really very striking feature, myxoid with collagen and wavy cells, hyalinized blood vessels, as you could see here. This is really all you need to call it a neurofibroma in these cases. Usually neurofibroma, they are not attached to a nerve like schwannoma, but some nerve tissue may be embedded in it, and usually they are not well defined as schwannoma. And usually they are hypocellular, not intermixed with hypercellular and hypocellular, like Anthony A and Anthony B, as we in schwannoma. I just highlighted some of the features because this is important in this case. So this is, to me, when I saw this, the collagen bundles, very prominent, the myxoid areas, hyalinized blood vessels, some mast cells were there. This is typical histology of neurofibroma. So I always like to prove it by immunohistochemistry. Next slide. This is S100. You can see S100, the brown staining indicate diffuse positivity. All this is positive. The hollow is the myxoid areas that are hypocellular, but you can see it's all positive diffusely. And when you see it diffusely, it's 100 positive with a morphology, it's almost diagnostic that this is a neural tumor, in this case, neurofibroma. Next slide. Epithelial membrane antigen was negative. This just to rule out meningioma, because meningioma is epithelial membrane antigen positive, and this is in the differential was in the clinical setting in this case. Next slide. CD34, I did it for two purposes. The clinical was suspicious for hemangioma, and you can see it's completely negative. So there's no blood vessels, very few blood vessels, as you can see, but this is not really a vascular tumor, as you could see it in the operation. CD34 sometimes can be positive also in neurofibroma, and this can be distinguish it from schwannoma. So CD34, when it's positive in a neural tumor, it is sometimes indicating 50% of the cases it could be positive in neurofibroma. So this case was called the neurofibroma. I did the other things, immune staining, actin, and desmin, and I just exclude all other differentials. So this was case called a neurofibroma benign of the skull.
Dr. Athana, my diagnosis was hemangioma.
No way I'm not a neurofibroma.
Absolutely. When I went in, I thought this is a hemangioma.
This is typical.
Very typical appearance. But this is the message. Why are we presenting this? Because this is the message. You cannot just keep thinking of the normal or the expected or what you would love to have. You will have all kinds of things, but just keep thinking about them.
So for the students in the room, if a medical student actually asks neurofibroma,
in this case,
He will
would
fail.
fail despite the fact that he had the right to answer.
Absolutely.
Because he should have presented his thinking process. And if the actual diagnosis is neurofibroma, he should have mentioned it.
Sure. Andrew Kay is an Australian-based Melbourne neurosurgeon. He's one of the giants of neurosurgery in the world. He's a close friend of mine. And look what he says when he looked at these interosseous fibromas. This shows the need for the neurosurgeons to be accustomed to the unexpected. You have to be accustomed to the unexpected like you are accustomed to the expected. So what is interosseous neurofibroma? How come? Mechanism. Small nerves, they enter various bony foramina and fissures with the blood vessels. So you will have nerves, little nerves, inside the diploid channels of the bone. Not only the bone of the skull, but any bone. So they can originate from the periosteum or endosteum or osteal cortex, or which is the commonest diploic tissue inside the bone, in this case, the skull. Are they common? No, very rare. They constitute very small percentage of primary brain tumors. Only 50 cases of intraosseous neurofibroma has been described. They usually occur before the age of 30, female more than us, lucky us, and it can affect any bone, but mainly the mandible. And it was suggested, why the mandible? Because you have the nerve, the submandibular nerve going into the canal within the mandible. They say, oh, this is common because the nerve goes through the mandible, but in others, there is no such a thing. Examples, maxilla from India. Look at the maxilla, open mouth, this is maxilla, and you can see the tumor. From South Korea. This was associated with the neurofibromatosis. Note that not all the neurofibroma are associated with neurofibromatosis, only about 10% are associated with neurofibromatosis type 1. From Japan, 2018, malignant tumors in the mandible, destroying it completely. And this is the PET scan showing the uptake in the previous case, also involving the vertebrae. Central neurofibroma in this girl, affecting her maxilla from India. Look at this mass. Another affecting the mandible, the maxilla, and the orbit. Here's the orbit. And these are the other lesions. Interosseous neurofibroma of the tibia, inside the tibia, inside the bone. And the vault of the skull, these are the cases. From Turkey, in the parietal bone. From USA, 2003, again in the orbit. And the skull, frontal area. This comes from William Shaker, a great skull-based surgeon, a friend of mine in Washington, D.C., United States. Frontal bone. Temporal bone. So they can affect anything. Cranium of a young patient from South Korea. And this, I think, recent one, 2014, from India. And they looked into literature and they found that 8 cases have been reported. Intraosseous skull vault neurofibroma. This is one of them, and this is the cases reported in literature. So our case is rare, maybe the 10th case or 11th case in the world. Interosseous, Morocco. Moroccans are very active, very much active than us Jordanians. Tunisia and Morocco are very active in this field. And you can use the FDG PET to show the lesion. Again, back here, this is the lesion. And this is the FDG and thallium scan, which you can use to differentiate. And these are the authors and their cases in the vault and in the skull base. And this is the latest paper from Italy, 2018, in neurofibroma of the skull. So what about our case? This is the postoperative, immediate postoperative the following day. We don't postpone our follow-up until another day. It is done the following morning, whatever the time of surgery that we finished. And this is the girl doing well. She was discharged on the 4th postoperative day. Discharge summary, the full discharge summary, not the flimsy piece of paper, which is useless, actually absolutely useless. And we should be ashamed of ourselves of writing this silly piece of discharge summary. Patient admitted on the 12th, discharged on the 15th. يراجع العيادة في مش عارف ايش. PT scan was done. Oh, كلام فاضي. Nonsense. Total nonsense. Just filling gaps, filling spaces. 1 year follow-up. 2 years. Why am I filming it? This is a benign tumor. Benign tumors can change into malignant. Neurofibroma can change into neurofibrosarcoma. So I need to follow that, especially with the attachment to the dura and so on. So this is the reconstruction using the titanium. Very good. And this is how it appears. Again, showing you the documentation power. If you document your cases, then you are powerful. And this is the girl herself. 3 years later, 4 years later. These are actual pictures every year. She comes from Iraq because I made her frightened. If you don't, you may have malignancy, so better to look after you well. 5 years, 7 years, absolute nothing. She's doing extremely well. Okay, with this we finish. Any questions or comments? Please, Dr. Sabah or Kamal.
لا أمل من الشكر إليك أبدا، ونحن تلاميذك ولن نتخرج أبدا. شكرا لك. سؤال قد يكون سخيف، لماذا الصداع؟
Because, yeah, the bone, the periosteum and the industrium is supplied by nerves. So when they are stretched, then you will have headache. If you open the dura and you put your finger on the brain, there is no pain. So brain has no nerve endings and it is painless. Yes, absolutely. But the dura is stretched, the periosteum is stretched, the industrium is stretched, and they are richly nerve supplied. So, Mahmoud Nisan, neurosurgeon.
Can we run back to the differential diagnosis to see the angiolipoma?
The angiolipoma case, and you like the picture, hello.
Because I want to say, how many doctors remove lipomas from the skull in their clinic?
So many, and so many had disasters. This one?
It looks like a mass of the skull, but inside.
So the message is don't do anything unless you are absolutely sure. Deep inside you, because you are not knowledgeable, you would say, oh, this is sebaceous cyst. خليني افتحها في العيادة أخذ لي 200 ليرة ولا اللي. And then you will be up to surprise. Don't open any case unless you are sure, or at least you are ready to deal with it. I know of a case of AVM of the skull that was opened in the clinic. Patient died in the clinic. I know of cercoid aneurysm that was opened in the clinic, and the doctor ended in jail because for him it is sebaceous cyst. And just one week ago, I received a report, really silly radiology report. I'm not going to mention the name, of a boy with diagnosis of sebaceous cyst, and the lesion is eating the bone. So I could not help myself but raise the phone and say, my dear man, why did you diagnose sebaceous cyst? And this is
yes.
He could not answer me because this is the only thing he knew. And he had to put his signature there. No accountability, no responsibility, whatever he writes. So they feel free to write whatever they like. But I really made a warning for him. Anyway, please. Absolutely, absolutely, yes. So that's the message exactly. You know, people should follow and pursue the diagnosis, not just in the fiche. I'm gonna do. Me and Rafa did to me.
Besides knowing this can be a disaster, we must know also that there is lesions from their examination. They can be excised without having a CT. For someone that a CT scan is a big issue for him.
Yes.
What I mean to say, everyone saw one of these cases with the end result histopathology. Is lucky to know the texture of that lesion.
By examination. Sure. Sure.
Evaluated.
Absolutely, absolutely agree. And again, this is a good point, Jamil, that people would say, oh, let's not do CT. Why should I bother and ask the patient to pay 50 JDs or 60 JDs or 80 JDs for something which is I'm unsure what it is? No, it's better to do it and be safe rather than sorry. Please.
So my question is, what's your diagnostic workup for someone that shows up with a skull lesion? And when do you proceed with a biopsy?
Sure. Biopsy is not in my book at all. I need to have a very short list differential diagnosis, which I will act accordingly. I've never ever admitted a patient to hospital without a plan. I've seen him in the clinic and made all the necessary investigations. So when he's admitted for definitive plan. As we mentioned, the examination is very important. The feeling, the edges, the blah, blah, blah. And then I would not start with the most simple skull X-ray. I would start with CT and MRI and insist on both. I need to know the connections, I need to know the vascularity, I need to know everything. So I don't go for biopsy, I go for definitive lesions. Even in gliomas, I don't go for biopsy. I believe in excision of 85% to 90%. These are the protocols of the world that has been laid to the people to follow. But people here in this country and in the Arab countries, they don't want to follow rules. They have their own rules. They make this and they teach their residents the false information, small biopsy and radiotherapy. This is a mistake. Thank you for your question. Any other questions? If nothing, thank you. We'll see you next week, inshallah.
Hi, Dr. Sabea. Can you hear me? Can you hear me, Dr. Sabea?
See you, man.
Yeah, can you hear me okay? Musindo, are you there?
Yeah, I was very fascinated by the topic and the lecture was very good.
Okay, Musindo, can you want to be introduced to Dr. Sabea?
So, are you staying for a while?
I don't know. I think he may be, I don't know if they're going to do questions. We may have to just end it. Let me just wait a second.
Medicine is science. Guidelines or protocols.
Jordan جزء المقالة هذا مشكلة ما تقدر لكم شو القضاء نفس الشيء متصل فيه no accountability no responsibility no supervision لما حكيت عن الريبورت اللي حكيت عنه how would you know?
Hello, Musinda, you still there?
Because he doesn't know. He did not think about the.
You're muted there.
عندنا هون الناس تعرف كلمتين في الطب.
Musinda? Hello, Musinda. Okay, we're going to end this.